I'm going to read verbatim from the program, the bio. Feel free to chime in with me. Dr. Deb Finnell has specialised in mental health and substance use for most of her nursing career. From her grounding as a registered nurse working in inpatient psychiatry, she's expanded her role to that of clinical nurse specialist and then nurse practitioner. Who's bored? You want to know the real story, don't you? So I've had the pleasure to have dinner with Deb and a few others last night, and I've got some observations that do talk to her profile. So I want to introduce it in a slightly different way. So Deb was at the University of Buffalo before she was actively recruited to Johns Hopkins at Baltimore. And when we asked about this last night, I said, you were actively recruited. She was way more humble than that. But I sort of switched onto it because she was flying to Baltimore, a car from Johns Hopkins picked her up, someone actually ordered her a hotel room, and there was a contract in the car when she got there. I think that's actively recruiting someone. It's interesting when you look at a profile as well. I did a bit of a Google search, and she publishes a lot of op-eds as well as academic, kind of journal articles. And I think it's sort of testimony to reach and advocacy and the work that she does. And if you look into how she does her work, she does a great job of holding research funding and doing research in a traditional way, but she's very applied in what she does. So in terms of a difference on the ground, in terms of practice, but also in terms of pedagogy and how we teach nurses and how we work with nurses with the information that she distills. In fact, when we were trying to book her for this gig, we gave her some open dates, and she said, look, I'm teaching in the fall, so we're going to have to work around that. And I think it's kind of testimony to her commitment to education. When I shared a cab with her back to drop her off after dinner, I'd sort of got the sense at dinner, she got a lot of humility and she's very humble. And she said something to me in the cab. She said that she came to academe late. And I thought, you didn't, come from a great practice background, done magnificent work with veterans, and have moved into an academic piece where she's actually traversing a number of areas to bridge that difference or those differences potentially between academe and practice, and academe and education, and practice and education. She does a great job, and she's also very comfortable in her own skin to leverage others, and I think that's such a great thing to have. She embodies really the respect that she advocates for in practice and in dealing with marginalised populations. And so I'm delighted to have met her, to have spent a little bit of time with her, and to introduce her to you tonight.
John, thank you for the introduction, Elizabeth, thank you. A little scared there when you went off script, but so I thought, oh, what's he gonna say? So thank you all for coming tonight. I am honored and I am humbled to deliver this 2017 Marion Woodward Lecture. This year's focus on mental health and substance use problems provides me with the opportunity to discuss one of the most vulnerable and one of the most stigmatized populations in the world. Given the prevalence of these disorders and the ever-present headlines about the opioid use epidemic, every one of us is impacted as members of society and certainly as healthcare providers and educators. So similar to a sermon, I have 3 points. So there's 3 areas that I'll address tonight. For each, I'll talk about what is known and provide examples of what I've done in each of these areas. I will end by presenting what I believe still needs to be done, and there's much to be done. My goal is to urge you to examine your perceptions and your paradigms about mental and substance use disorders and challenge you to consider how you can help to remove the stigma that is a significant barrier for this vulnerable population as they seek and receive health care. So why is this important? To bring it to your home, according to the 2012 Canadian Community Health Survey, mental health, 6.1% of the Canadian household population aged 15 to 64 had a mood or anxiety disorder in the previous year, and 3.8% had a substance use disorder. About 4.9 million Canadians aged 15 and older experienced a need for mental health care in the previous 12 months, and of those, 600,000 felt that need was unmet. 600,000 felt that need was unmet. Additionally, 1 million felt the need was partially met. 39% of those 15 to 24 years old consulted a resource about emotions, mental health, alcohol, or drug use in the previous year. So keeping in mind that as nurses, we are among the most trusted profession, we have the closest contact with patients, and we have the most prolonged time with patients, we can help to address some of the needs of this population if we have the will to do so. We've talked a lot about stigma earlier in the panel today, and from the Mental Health Commission of Canada, they suggest that stigma is one of the key barriers to preventing people from seeking treatment. Stigma engenders labeling, stereotyping, and fear of persons with mental illness. So as you saw from the graphic advertising this lecture, it's all about the brain. And it isn't all about the brain, but I'm going to focus on that for this lecture. Advances in neuroscience have led to a better understanding of the brain's structure and function. Yet, what do we mean when we say brain-based disorders? These disorders result from neurobiological dysfunctions that make an individual sensitive to both internal and external stimuli. The criteria for these disorders are outlined in the Diagnostic and Statistical Manual, and they're based on what we can observe. They're based on what the person reports, but not on etiology. The evidence points to structural and neurochemical dysfunctions. This omission in the DSM, I believe, reinforces the behavioral paradigm that the person should be able to control his or her behavior. And it also reinforces the moral paradigm that failing to control themselves, these people are weak-willed or somehow personally responsible. To stop the stigma, we must focus on what we cannot directly observe, that which is disordered in the brain. How many times have you heard someone say, "Why can't you control your drinking? Why can't you control your anger or your impulses?" If the human brain has an average of 86 billion neurons, with an average of 7,000 connections each, how much control do we have over its functions? We can't control why we get these impulses, but we are responsible for managing our thoughts, our feelings, and our behaviors. The central area of the brain, the limbic brain, is the primary driving force for our survival. Notably, the limbic brain is unconscious, it has no language, and no conscience. Buried deep in the center of the brain, the limbic system is concerned with both subjective emotional experiences and with changes in body functions associated with emotional states. The limbic system is intimately wired to other structures of the brain. It's involved in aggressive and sexual behavior, and it's also implicated with pleasure, memory, and learning. The manufacturing sites for the key neurotransmitters, dopamine, serotonin, and norepinephrine, are located here. Manufactured in the substantia nigra, dopamine is associated with pleasure. This gives us our sense of well-being, and it's responsible for our appetitive and reward-seeking behavior. Neurons that lead from the substantia nigra to the frontal lobe, where the frontal cortex is dealing with those most integrative brain functions: thinking, conceptualizing, and planning. A disorder of this system, therefore, will impact decision-making. Excess levels of dopamine give rise to exhilaration, superior confidence, a sense of power and control, and joyous excitement. Such conditions might be associated with schizophrenia, mania, and cocaine intoxication. Dopamine deficits correspond to a loss of pleasure, feeling empty and joyless. So, common feature, this is a slide from the National Institute on Drug Abuse. A common feature of alcohol and other drugs is their ability to activate specific areas of the brain that give rise to those pleasurable feelings of reward, motivation, and reinforcement. This reward pathway is the mesolimbic dopamine system. Though particular substances have different mechanisms of action, each increase the activity of the reward pathway by increasing dopamine. So that increase in dopamine, that sense of exhilaration and pleasure. Here, the locus coeruleus manufactures norepinephrine. This neurotransmitter is associated with our flight or fight response. Here, the projections ascend to the higher brain centers that regulate attention, arousal, and our sleep-wake cycle. Excess norepinephrine is associated with extreme anxiety, panic states, loss of appetite, aggression, and violence. Deficits are associated with thought confusion, acute depression, chronic fatigue, lethargy, loss of sexual drive, and hyperactivity, as we may see manifest in people with attention deficit hyperactivity disorder. Perhaps one of the systems that's more widely known is the serotonin system. Here, the raphe nuclei in the pons and in the midbrain innervate the entire brain. These nuclei manufacture serotonin, a neurotransmitter that has a prominent role in mental disorders, especially in affective disorders. Serotonin inhibits our activity and behavior. It controls rhythms, sleep, cycles, mood states, and it plays a role in the perception of pain and regulation of temperature, reduces feeding, aggression, play, and sexual activity. Excess levels of serotonin are associated with hypoactivity, increased sleep time, behavioral inhibition, fearfulness, and harm avoidance, while deficit levels are associated with hyperactivity, jitteriness, aggression, paranoia, insomnia, and impulsivity and depression. Serotonergic system dysfunction has been associated with increased lethal suicide attempts and suicide. Homeostasis is a key principle to understanding these brain-based disorders. For some, balance or feeling normal may be experienced when they consume alcohol or drugs. Why is that? Well, to use an example, endorphin regulates our pain perception. A low endorphin level translates into a heightened perception of pain. Ingesting heroin promotes endorphin release, and it gives that sense of well-being, relaxation, and a feeling of being capable of handling any form of stress and anxiety. That acute effect is followed by an opposing neuroadaptation, and the response is tolerance, a need for markedly increased amounts of an opiate to achieve the desired effect, or a markedly diminished effect with continued use of the same amount of opiate. A withdrawal syndrome occurs as the drug is excreted from the body. In turn, there's a neuroadaptation and a physiological adaptation to restore equilibrium and an opiate-free state. The experience of craving, that is, a strong desire to use the opiate, is neurobiologically driven, and that helps to explain why a person continues to use the drug despite the consequences. We do make observations and assumptions based on a person's affect, appearance, behavior, and speech. These are branches of the human tree. Those branches constitute the moral and the behavioral paradigms. They form our attitudes and our perceptions about others and may inadvertently contribute to the stigma experienced by persons with mental and substance use disorders. I ask you to consider integrating the evidence related to the neurobiological roots, whether as a direct care provider, an educator in healthcare or higher education, an administrator, or any other position that you currently hold. So knowing about the neurobiological basis is one thing. Feeling it is another. What must it feel like to be empty and joyless? What must it feel like to be profoundly depressed? What must it feel like to have a craving for a substance that leads to use despite the consequences? These are not willful or intentional behaviors. Rather, they're driven by what occurs in the brain, stemming from a disorder in the brain structures and functions. Again, I emphasize this in no way recuses the person from being responsible to manage their health condition. Yet by shifting the paradigm from a moral one to a biological one, just as has occurred with leprosy, with epilepsy, and AIDS, this vulnerable population may experience less shunning and rejection and thus be more willing to seek and accept treatment. Education about the neuroscience can be used to overcome that stigma that persists because of that moral paradigm. The blaming and shaming people that are afflicted because of their biology, rather than addressing them as anyone else with a chronic medical problem that is treatable. Let me provide some examples of what my colleagues and I have done to promote this message. One of my first publications was the case for teaching patients about the neurobiological basis. And I've been promoting this message for over 2 decades. It was the responses from my patients that spurred this publication. My practice was grounded on providing that evidence to patients, and what were their responses? Quote, "I thought I felt this way and drank because I was weak-willed. I've read about this, but I understand it more clearly now." Others were able to make the connections between their symptoms and their substance use. Quote, "I was depressed before I used cocaine. Now I know why I'm depressed more after I use and stop." Our 2013 publication on the right in Nursing Clinics of North America was an appeal to nurses to provide this critical health information to remove the barriers to behavior change and to remove the barriers to treatment for persons who could benefit from specialty treatment. When the first ever United States General Surgeon's report on alcohol, drugs, and health was published in 2016, the first ever report, 2016. My fellow board members of the Association for Medical Education and Research in Substance Abuse, fondly known as AMERSA, and I wrote an editorial heralding the Sentinel publication. Notably, the second chapter of the Surgeon General's report was devoted to discussing the neurobiology and explaining that substance use occurs along a continuum, from at-risk use to a substance use disorder. Finally, this evidence was front and center in a document intended to help inform policymakers, healthcare professionals, and the general public about effective, practical, and sustainable strategies to address these problems. In my role as a nurse practitioner, my prescribing practice was grounded on education related to the brain structures and functions. Rather than vague explanations about auditory hallucinations, for example, I shared scientific publications, such as a meta-analysis of neuroimaging studies. And yes, this is one of the images that I used in working with a patient. A patient who believed the auditory hallucinations were due to unseen shrapnel in his head came to accept the scientific evidence. He had been told by a previous provider that taking the antipsychotic medication would, quote, "melt the metal," unquote, and the voices would go away. Also, as a practitioner, I wanted a deep understanding of the pharmacodynamics and the pharmacokinetics of the medication I was prescribing. I worked with a young man with a schizoaffective disorder who was reticent to take medications, and he was willing to come into treatment because he had been living in a residential or a recreational vehicle and moving between campgrounds in the US to stay, quote, ahead of the enemy, unquote. He was drinking alcohol, he was smoking marijuana throughout most of his waking hours. And as he was in residential treatment, I was able to see him with some frequency. Over the course of 3-hour-long meetings, I provided education about the brain and associated the symptoms he was experiencing with their neurobiological underpinnings. Then I provided information about various antipsychotic medications. I used this graphic to explain the differences in the receptor affinities for different medications and gave him the rationale for the medication that I was recommending. The next day, he returned asking if he could start quetiapine at a low dose that I had recommended. The following day, he came back saying he slept well for the first time in ages and was feeling no untoward effects. Over the course of time, he came back to ask for small increases in medication And then one day he came to my door and he said, Dr. Fennell, I think I need something that's going to impact my dopamine receptor sites, specifically the D2 receptor sites. So after several years of teaching patients about neurobiology, I secured funding from the Veterans Administration to produce a video. This 20-minute video, Alcohol in the Brain, provides information about how alcohol affects the brain, how the brain recovers in response to abstinence or withdrawing of alcohol, in response to behavioral and pharmacological treatments, and in response to participation in mutual support groups. I then produced a second video based on the Rethinking Drinking booklet from the National Institute on Alcohol Abuse and Alcoholism. This 20-minute video focuses on the dangers of at-risk alcohol use and provides research-based information about drinking, strategies to help people consider whether and when to change drinking, and resources for professional help and mutual help groups. My doctoral students and I conducted a study wherein we asked participants to choose one video, and we measured their current level of risk associated with their alcohol, their readiness to reduce alcohol use, and their knowledge related to alcohol. In our sample of 129 adults aged 21 to 65, 99% of the 116 males and 4% of the 13 females were at risk based on our screening with the Alcohol Use Disorders Identification Test. Knowledge scores increased slightly from pre to post-test, and though not significant, those who watched the Alcohol in the Brain video increased their readiness to decrease alcohol use from before to after watching the video, and the readiness scores went in the opposite direction for those that chose the Rethinking Drinking video. So now I want to shift to my second point, words matter. The words that we intentionally and unintentionally propagate the stigma experienced by persons with mental and substance use disorders. These words depersonalize people, depriving them of individual or personal qualities and personal identity. In a 2014 publication, our editorial board of the Substance Abuse Journal appealed to authors, to reviewers, and to readers to use language that, one, respects the worth and dignity of all people, or people-first language. Two, focuses on the medical nature of substance use disorders and treatment. Three, promotes the recovery process. And four, avoids perpetuating negative stereotypes and biases through the use of slang and idioms. In 2015, the International Society of Addiction Journal editors issued a statement encouraging the use of non-stigmatizing terminology. An endorsing editorial by my colleague Rich Seitz in the Journal of Addiction Medicine followed in 2016. And in our reviews of manuscripts, we refer to our work that we did into the International Society for correcting authors who use stigmatizing language to reduce or hopefully eliminate it from our journal, Substance Abuse. In January of 2017, Michael Botticelli, then director of the United States Office of National Drug Control Policy, issued a memorandum to heads of the executive departments and agencies, citing those previous publications and the Surgeon General's report on addictions. Notably, the memo addressed the neurobiological basis of substance use disorders from which people can and do recover. To quote from that memo, substance use disorder, the most severe form of which is referred to as addiction, is a chronic brain disorder from which people can and do recover. Nonetheless, sometimes the terminology used in the discussion of substance use can suggest that problematic use of substances and substance use disorders are the result of personal failing, that people chose the disorder, or that they lack the willpower or character to control their substance use. However, he goes on, research shows addictive substances can lead to dramatic changes in brain function and reduce a person's ability to control his or her substance use, and that repeated use of these substances powerfully alters brain chemistry and the function of brain circuitry to create a neurobiological disorder. Two common questionnaires that are used to assess perceptions and attitudes are the Alcohol and Alcohol Problems Perception Questionnaire, developed by Shaw and colleagues in 1978, and the Drug and Drug Perceptions Questionnaire, developed in 2006 by Watson and colleagues. Both of these questionnaires are widely used to measure healthcare providers' attitudes and perceptions. My colleagues and I wanted to administer these questionnaires to our students as part of our project that we were evaluating. Yet as we reviewed the items, we noted terminology that is now, years later, viewed as pejorative and stigmatizing. The three of us undertook an independent review of the 30-item alcohol questionnaire and the 20-item drug questionnaire, revising items to develop contemporary person-first questionnaires. We compared our versions and resolved differences to develop the final forms. These first-person measures have been administered to over 400 pre-licensure nursing students at Johns Hopkins School of Nursing and over 200 Master of Science nursing students at the University of Pittsburgh. We will use these data to establish the psychometric properties of these versions of the questionnaire. There is clear evidence that nurses, like many other healthcare providers, are ill-equipped to address the continuum of substance use. When content is included in curricula, the dominant focus is on those with the substance use disorder, so those at the farthest end of the continuum. While recent efforts have focused on early identification of persons who are at risk because of alcohol and other drug use, there has been slow uptake of the evidence in support of screening, brief intervention, and referral to treatment in nursing curricula, continuing education, and in healthcare settings. In a 1987 study, Hoffman and Heinemann reported that there was 1 to 30 contact hours related to alcohol and health among the nursing schools that they surveyed. Nearly 3 decades later, Savage and her colleagues found the mean number of contact hours related to alcohol and health in Baccalaureate of Science of Nursing curriculum was 11.3 hours, with a range of 3 to 38 hours. So over that span of time, we as a nursing academic community did little to change this content. The limited content hours related to substance use is concerning, considering the serious public health issue of at-risk alcohol and drug use and the high prevalence of use worldwide. Our team conducted another study, a cross-sectional descriptive study, to determine the extent to which screening, brief intervention, and referral to treatment, or SBIRT, Content was included in current curricula for the advanced practice registered nursing students. And we also wanted to know if they were evaluated on their competency to deliver the set of clinical strategies. The survey was distributed electronically to random selection of US-based APRN programs with 90 responding. The mean number of hours devoted to alcohol, drug, and tobacco expert was 7.3. Among responding schools, alcohol content was most common, with about 93% of the schools. Content on brief intervention, 57%, and referral to treatment, 60%, was less common than the alcohol screening. Note that fewer schools reported content for drug screening, 63%. Note also that this survey was conducted in 2016-2017, as the opioid epidemic was raging. 63% for brief intervention and 39% for, 39% for brief intervention and referral to treatment at 48%. And less than a quarter of the schools included expert competency assessment for alcohol or drug use. The United States Substance Abuse Mental Health Services Administration has been providing funding for medical schools, nursing, and other health care providers to integrate this content into curriculum. We integrated this content into our graduate, our master's level curriculum, and our pre-licensure programs at Johns Hopkins School of Nursing. We utilized a 4-phase process to engage faculty, adapt the content to the curriculum, implement the change, and evaluate, revise, and promote the new content. So we have 13 modules that are integrated into relevant courses across the curriculum. After receiving the core modules, the students complete a computer-based simulation where they demonstrate their competency in applying motivational interviewing techniques to engage in a patient-centered conversation and assess, prevent, or reduce alcohol use. After completing that program, students submit their certificate of completion as evidence of mastery. Modules on the neurobiological basis, behavior change framework, identification and management of withdrawal, and implementing SBIRT in practice are integrated in corresponding courses across the curriculum. Our work has been guided by the American Association of Colleges of Nursing Essentials for baccalaureate nursing practice, for master's education, and for doctoral education. The placement of each model is guided by the fit of the content with the course, and we developed a document to map the course description, the course objectives, the module description, and module objectives with the corresponding essentials from the American Association of Colleges of Nursing. That curriculum map serves as a reference for the overall, as the overall curriculum is reviewed for ongoing quality improvement and to ensure that we prevent curricular drift. While we were focusing on the future nursing workforce, including those seeking advanced practice roles, we realized the need to increase the knowledge and skills of the current nursing workforce. In this project, we partnered with colleagues from the University of Pittsburgh who had similarly received funding from the Centers for Disease Control and Prevention and the American Association of Colleges of Nursing. In this project, we developed an online program for all levels of nurses. 2 modules provide the foundational content for the program, an overview of alcohol screening and brief intervention, and fetal alcohol spectrum disorder. One module focuses on alcohol interactive medications, and 6 modules focus on the delivery of ESPERT to diverse populations. 3 modules were designed to provide information particularly for nurse administrators, clinical nurse leaders, and nurse informaticists. And finally, a module focuses specifically on implementing ESPERT in practice. And we will be disseminating this soon to the over 3 million nurses, registered nurses in the United States and beyond. We also developed an online program with funding from the Substance Abuse Mental Health Services Administration for healthcare providers who are seeking foundational knowledge related to substance use screening, brief intervention, and referral to treatment, as well as for the healthcare provider who is a preceptor or a mentor for a student or a new provider. This program culminates in a learner observing a healthcare provider implementing this set of clinical strategies and evaluating that interaction using an established ESPERT proficiency checklist. The learner then has the opportunity to see how the ESPERT expert provides feedback to the clinician. So what is yet to be done? If we are to change paradigms that are barriers to effectively serve our patients, we must believe the evidence and we must promote the evidence. It is important for nurses and other healthcare providers to disseminate what we know about the neurobiological basis of mental and substance use disorders to individuals, groups, and populations. We can and should translate this evidence to patients, families, and the public. This message can be carried through social media, editorials, professional presentations, peer-reviewed journals, and lay literature. We also need studies to examine the efficacy of providing this information to persons with these disorders, and studies focusing on what type of information is effective and for what types of populations. Concerns about the 17-year time lag in moving research to practice is not new, yet it is unresolved. Greater efforts are needed to translate evidence into practice, and such work is ideal for implementation science by the PhD and translational projects by those with a practice doctorate. Greater efforts must be taken to build capacity of the next generation of nurse researchers, of nurse educators, and practitioners to address the global burden of mental and substance use disorders. Nurse leaders should follow suit with initiatives such as your own here, the British Columbia Center on Substance Use Addiction Nursing Fellowship under the direction of Cheyenne Johnson. We need a global set of core competencies for nurses caring for people across the continuum of substance use. Nurse leaders from Canada, the United States, the UK, and other countries are currently undertaking this work. Nurse leaders in the US have mapped content related to substance use and substance use screening, brief intervention, and referral to treatment to the American Association of Colleges of Nursing Essentials for the baccalaureate, master's, and doctoral nursing. As we disseminate this work, we encourage nurse educators to revamp their curricula, guided and inspired by our work. Such efforts will help advance the knowledge and skills of nurses across all levels of education, so collectively we can address the needs of this vulnerable population. I want to acknowledge the funding support for the projects that I've discussed in this presentation, and most importantly, I want to acknowledge the partnerships with my colleagues and students across several institutions. I'll provide a quiz on all of this information at the end, but I'm happy to provide all of the references that I've used in this presentation. And finally, I want to thank you for coming to this lecture, for the gracious invitation to come to this honored lecture series, and for the hospitality that's been extended to me from the City of Vancouver in general, and from the University of the British Columbia School of Nursing in particular. And now I think I may have some time for questions.
Thanks, Deb. We've got microphones on both sides, so please feel free to come up and pose some questions. Great, Colleen. I thought you might start us out.
Thank you very much, Deborah. That was a lovely talk. And I particularly appreciate your emphasis on language. It's so important. And I love the fact that you're taking it at such a structural, organizational level to try to do something through our publications. So I just really commend you for that. I studied violence and trauma, and so I'm really interested in those intersections. And recently, I've been very fascinated by an article by a philosopher by the name of Lewis out of University of Toronto, arguing that when we connect trauma and violence to substance use, we can move beyond the disease model and see substance use issues and problems and harms as developmental. And I was wondering if you would comment on the extent to which your work has taken into account the role of trauma and violence, and say a little bit about that. Thanks.
Yeah, thanks, Colleen. Thanks for a real simple question. I would say that my work in terms of the intersection with trauma has been predominantly with veterans who are suffering from post-traumatic stress disorder. That's the population that I know best in terms of the trauma. And what we know is that trauma, remember that external stressor impacts the internal environment. So we have, the well-known cortisol adrenal response, but we also have a response that negatively impacts the brain. And so when we look at trauma in terms of the dysfunction that it creates within the brain, and then that attraction to substances that help to bring the brain back into balance, I think that's where I emphasize. And again, I'm going to come back to the neurobiological base. There's been some work looking at the symptoms associated with PTSD and the different types of alcohol and drugs that impact those symptoms in a positive way. So the aggression, the violence, the depression, all of those stem back to the very beginning when I talked about dopamine, norepinephrine, serotonin, and endorphin as well. So it's making that, again, in my work that I did, it was explaining to people with PTSD how that trauma creates neurobiological imbalances, and then how those imbalances then lead to their use of substances, how those substances change their feelings and their behaviors and their emotions. Thanks for that question.
I learned a lot today. Thank you. My students were doing a project in the area of meditation and health. And as we were doing some research in that area for articles, there is some some people say that yes, meditation is helpful for health and healing. We came across an article by almost about 100 years ago by a psychologist in Russia, Dr. Luria, who had written that we know so much about the various parts of the brain and their function, even at that time, but we know very little about the connections between the lobes and what kind of, if there are any issues with the connections, the nerves, what kind of, like the traffic, what kind of effect those things have on us and our behavior. In your research then, did you ever look into that? Is anyone doing research in that area? Because I'm interested in that area as to the biology is one thing, each lobe, but the connections, we know if the electricity connection might be working there but not there, and yet we haven't looked at it in the brain.
Yeah.
Thank you.
Yeah, a great question. I don't know of specific researchers that are looking at that, but clearly we do know that the lobes are connected in order for this holistic function of the human and animal species. But we also, when we talk in terms of, and I talk in terms of dopamine, on that chart that I showed with the receptors, there's different types of dopamine and different types of dopamine receptors. There's serotonin receptors in our gut too. So it's complicated. But when there's a disruption in one area of the brain, there is going to be some kind of disruption in another area of the brain. I think that as we get more, build more evidence around the neuroscience, and as we have more tests that are available and that are affordable outside of research, such as MRI testing or PET scans and the like, we'll have more information about that. But also keep in mind, every single one of us is unique. And so how my brain operates is going to be different from how your brain might operate. And so we still have a lot to learn. Just think in terms of the number of neurons and the number of synapses. And how can we possibly begin to study all of that universe? It's both daunting and it's also exciting. Yeah. And there are researchers that are doing very specific kind of areas of the brain in terms of research, like the right nucleus accumbens. So there's researchers that only look at that tiny little area of the brain. So opportunities abound. It's like space in the deep ocean. We have a lot to learn.
Thank you so much, Deborah. I was so struck by the poignancy of the stories that you told about the young man being informed of the neurobiology and finding a way to make that useful, and that the power of that piece of information in making a change, and also reflecting on how incredibly forceful it could be if we could work with the nursing profession writ large to play a very significant role in shifting that issue of stigma. And so I wondered, in the work you've been doing on curriculum to young nurses and nursing students, are there any of those similar stories of powerful pieces of information or powerful aspects of the learning that seem to have a profound effect on learning?
Yeah, great. Thanks for that question. So these are the same kind of stories that students hear. These are the same kind, and I think many of us are moved by stories as much as we are by here's the raw facts in the evidence. And so I use those stories in particular because, this was over a decade ago, and I can still see their faces. It's those stories that really help students to see how this can come alive, to see the power of how you can take evidence and information and move it into teaching patients. So I think the more that we can do that, the better. The teaching, that first publication I did, and then the later one, was to get out some of those stories into the literature for students and clinicians to see and to read. And how sad it was for me to have that veteran sitting in front of me saying, this previous provider told me that this antipsychotic medication was going to melt the metal in my head. I couldn't live with that. And I also have had colleagues in my that I've worked with who said, I really don't agree with you teaching patients or giving people this information because, and I said, why is that? He said, because they're going to know more than me. And I said, good. Yeah.
So we do have time for a few more questions. I've got one for you, Deb, that I've been thinking about. Just in the break, we talked about leadership roles in nursing within the area, and you talked to me about a chair, an endowed chair that couldn't be filled at Buffalo. And I'm struck by the expertise that was in the room this afternoon with the panel and your expertise tonight. And I'm just wondering, going forward, how we can address some of those leadership issues, whether it be a chair or whether it be some sort of configuration, about your ideas about vision for how we could be more fully involved and more fully appreciated, perhaps.
Yeah, thanks, John. So in the, I think one of the things in terms of how academe and healthcare have partnered or not has been because of some of the rigid boundaries that we have around the roles. And so it may be that if you're hired into an academic position, you're in that academic position. We have practice tracks at Johns Hopkins, and the expectation is that faculty who are hired in those practice tracks have about a week of practice. And that's great, and it's good. They negotiate kind of contracts with payback from the agency where they work comes back to the School of Nursing. But inevitably what I hear is, oh, she can't come to that meeting because she's in practice today. And there's that kind of attitude around some on the academic side. On the clinical side, it's also, well, you can't get away from the clinic today because you're scheduled with patients, and I'm sorry, but you're not going to be able to get released to go and do that lecture that you said you were going to provide at the university. What I think we have to do is create models that break down those barriers, where we can have the best of all worlds, where we can have someone who's able to teach as 60% of their time and 40% of their time in practice. I've been in those roles 2 different times. Both of those experiences made me a better practitioner and a better educator. So I think we need to create positions, whether they're joint appointments or dual faculty appointed roles or endowed chairs positions, that tear those barriers down and allow us to more fluidly move between those teaching and practice environments.
Thanks for that. Suzanne, did you have a question?
Hi, Deb. So
Hi,
great
Susan.
to have you here. And now you've gotten me totally off track. I'm interested in the fetal alcohol spectrum aspect of the research that you're doing, and if the care for those patients, and if you're seeing generational differences, and back to what Colleen was mentioning about the trauma as well. But I so appreciate your words of wisdom about how we maintain that practice. It's evidence in the research you've done that it is your practice-based component which has led to not only the education for the rest of the capacity building of nurses and other health professionals, but also for the curriculum you're developing and how that's being implemented in practice. So fetal alcohol syndrome and spectrum, we only began to know the changes in the patients you've worked with, or the things you've seen in some of the programs and the educations. What are differences and specialties for that area?
So let me say that I would defer that to my colleague who's not standing right here, but usually we're welded at the hip. So that, and the work that we've done in that joint project has been out of the University of Pittsburgh. They have had generous funding from the CDC, Center for Disease Control, for advancing education around fetal alcohol spectrum disorder and around caring for both the mom and the infant and subsequent generations with FASD. So I'll make sure that you're connected with Ann Mitchell. Yeah.
Thanks, Deborah. It's just been a delight to spend the afternoon with you and then hear your lecture tonight. I want to come back to the example you gave of the young man who, when you talked to him about the neurobiology, he was able to say and understand more about who he was and what he needed, which sounded to me like a story of empowerment. I was recently part of a session where a medical practitioner gave the neurobiology perspective. And I was with people that I work with very regularly, people who identify as using substances, who belong to, a group of people with past and current substance use who have lived experience. And we had a bit of a discussion afterwards, after the person had presented, pictures of the brain and how the brain was affected. And they did not have that experience that you described. They felt in many ways that explanation removed their agency. And, I really appreciated the answer you gave to Colleen about, the link between trauma and changing the brain. So I wonder if you can just talk a little bit about how, the use of neurobiology, doing it in a way that empowers people. And I know I'm asking a fairly difficult question, but some of the essentials of that, because I think we do not want to take away people's agency. We do not want to see them as helpless victims of a disease. We want them to be empowered and their care. So I wonder if you can just talk a little bit about how you did that and some guidance for us, I think.
Sure. So one of the things that we did, my husband and I, he's a social worker, and we had a private practice. And one of the things that we did is we looked at what are feeling states, what are behaviors, what are cognitions that are associated with all of these neurotransmitters that we know about and we have evidence for. And created a symptoms inventory rating scale. And in the luxury of private practice was that neither one of us were able to be paneled by insurance companies. so we couldn't bill for services. We used that to our advantage because we kept our rates affordable. We were able to guarantee confidentiality because we weren't submitting bills or diagnostic materials. We didn't have anybody coming in to look at our records. So we had the luxury of spending a couple of hours with people in that first visit. And it was a multi-page document that went through all of the various symptoms. Again, emotions, cognitions, behaviors that we drew from the evidence associated with neurotransmitters. And as we went, and they were organized in terms of different kind of logical sense of organization in terms of clusters of symptoms. As we went through that, it was, is this present, is it absent, and to what degree of severity? And it was the individual rating their own level of severity. As we went through that, we then educated. So we would go to, let's look at where this occurs in the brain. And we would match what those human kind of emotions that we have and the criteria that are listed in the DSM that don't have any trace back to a neurobiological root. And the initial intake was about 2 hours. And we had people who came in with complaints, with concerns, and they were riveted by this process. And in my experience in translating this to the VA system, where we built an entire program around that started with teaching veterans about neurobiology. We had a class, literally had classes. We changed it to an academic environment in the VA. And we taught people of all of the veterans. I had one veteran who said, "This does not make any sense to me. I don't like it. I am out of here." In our private practice and in that VA setting, with only very rare exception, it was, I now understand why, when I feel this way, I can trace it back to the neurobiological root. So we assessed and educated almost simultaneously. And again, it was, our experience was that it was incredibly empowering. And it was like saying to somebody with diabetes, just say no to Twinkies. What do? We teach about, here is what the etiology of this is. And we don't just throw insulin at them. We look at nutrition, we look at stress management, we look at their inequities that they may be experiencing and how to address those. We teach about self-care, about good foot care, all of those things. Why can't we do the same thing with this population?
I do want to thank everyone, especially Deb, for a great presentation. I'd like to thank you for coming out.